So recording. All right, I'll see it. All right. Well, thank you everyone for coming to this lecture series. I know it's been, I think this is probably number 3 or 4 again. I very much enjoy giving these talks. It's great to meet everyone kind of virtually, but sometimes meeting new faces, sometimes kind of seeing old kind of colleagues from old volunteer mission trips, which is great. But today we're just going to briefly talk about the management of polycystic kidney disease. We're going to focus a little bit on obviously the adult onset one, but today we're going to briefly kind of go over the etiology of autosomal dominant polycystic kidney disease. We'll go over briefly the autosomal recessive polycystic kidney disease. Excuse me for the typo. We'll go over the genetics briefly, the clinical signs, really the management and the role of urology when it comes to this disease state. And I have no financial disclosures. So polycystic kidney disease, what is it? It's a genetic disorder which is really characterized by the growth of numerous cysts in the kidneys. Also can be attributed to cysts grown in the liver as well as the pancreas. And these cysts cause significant enlargement of the kidneys, while doing so also kind of destroying and replacing much of the normal functional renal parenchyma, causing a general and slow decline of kidney function. And that decline of kidney function is highly variable, and which ultimately can cause kidney failure. In the United States, it's estimated incidence around 600,000 new patients a year will be given the diagnosis of polycystic kidney disease. It's in the cystic disease is the 4th leading cause of kidney failure in the US and worldwide as well. It's estimated roughly 12 million new cases will be reported. Again, the 4th leading cause of end-stage renal disease worldwide as well. And so not too many patients, however, it does impact end-stage renal disease significantly. And if we're looking at the genetics of polycystic kidney disease, if you look at the autosomal dominant, which is on the left side, which is the most commonly seen in adults, and then you have the autosomal recessive on the right, and that's usually seen in neonates as well as in children. And so we'll briefly go over that a little bit, but this is really due to a mutation in the PCKD 1 and 2 gene, which really drives the disease. And an autosomal dominant, you usually just need one affected parent to transmit that, whereas autosomal recessive, you need kind of almost like 2 hits. And if you're looking at the kind of the symptom or kind of the clinical manifestations or how they present, the adult onset is usually it's obviously the most common inherited form, but also the symptoms usually develop between 30s and 40s. They can begin earlier, even in childhood. However, the signs are really not evident unless you're getting unless the child's getting scans done for several reasons. About 90% of polycystic kidney diseases are autosomal dominant. So again, the most common. Only 10% are autosomal recessive, which is an even more rare form. And they usually begin in the early months of life or even as early as in the womb. And in the adult onsets, you really don't necessarily need genetic testing to confirm the diagnosis. The most common accepted kind of clinical diagnosis is presence of at least 2 cysts in each kidney. So it's not really a unilateral disease, it's usually a bilateral disease. And so 2 cysts in each kidneys by the age of 30, in addition to a family history of having a similar clinical manifestation in a 1st or 2nd degree relative. And that's good enough to give the patient a diagnosis. You can confirm with genetic testing, but obviously genetic testing is not offered to everyone. And just briefly about the autosomal recessive, again, very rare. However, it's also called the infantile polycystic kidney disease. And children are born with obviously the autosomal recessive, but not always. But sometimes they can develop kidney failure very early in life, even sometimes in the womb. And they usually develop kidney failure even before reaching adulthood, and that severity can range significantly to where babies are born needing dialysis immediately, or even having issues in utero to onset of dialysis again in their childhood years, and the symptoms increase with age. Again, extremely rare disease and usually not brought to the attention of adult urologists. often, and even in the setting of infantile, we tend not to see it too often as well. As that point, those kids have already need dialysis or already need bilateral nephrectomies and are getting transplants. And so if you're looking at kind of these kind of clinical manifestations and these risk factors, you really want to look at for these patients who have these signs with kind of a kind of fast drop in kidney function, higher volume of kidneys. So sometimes usually when we get renal ultrasounds, routinely we have almost a size. And so we usually have kidneys ranging from 7 to 10 centimeters. But if we start seeing kidneys going above that, you kind of want to kind of key in and seeing if the patient has cysts or not to cause that. Obviously, genetic mutations with the polycystic kidney disease type 1 and 2, family members, younger adults, below the age of 35, developing hypertension. Obviously, you want to rule out any other causes of hypertension, especially from a urologic standpoint, any adrenal issues. They can present with hematuria, even though it's rare, cystic infections or flank pain attributed to cysts. You can have obesity as well, associated with that, and then also urinary disorders or urine disorders, such as seen in chronic kidney disease, such as protein and albumin in the urine. And so from a symptoms and management standpoint, these are really kind of the big 4 hallmarks of polycystic kidney disease. And these are ones usually we as urologists get involved with the first 2. The second 2, usually nephrology is involved, and it's really kind of the mainstay of treatment is usually having an adequate follow-up with urologist, or excuse me, nephrology. However, that spectrum kind of ranges depending on which kind of type of practice you're in and how much nephrology assistance you have. And from a pain standpoint, and I actually had a patient earlier this week that had polycystic kidney disease, but also has a subsequent renal mass that I'm assisting with. But you want to avoid NSAIDs in these patients since they are nephrotoxic, and these patients will have a consistent and gradual decline in their renal function due to the destruction of their parenchyma. So you really want to be particular of what you want to give them. For pain, you can always offer a paracetamol or acetaminophen or Tylenol, and that can be beneficial. Obviously, we know that is not as helpful in terms of managing the pain compared to NSAIDs. However, you want to avoid it. You also want to rule out obstruction. You can have cysts that are very large that can cause compression to the renal pelvis. Again, you want to make sure that these aren't just parapelvic cysts. However, you can have some cysts, and this screenshot kind of shows a large cyst that sometimes can have a compression on the renal pelvis, and potentially cause almost a Diedel's crisis, like a UPJ obstruction. And if the hydro is secondary to a very large cyst and the cyst is amenable to aspiration, you can offer aspiration with sclerosing agent. Sometimes patients opt to get a lap cyst decortication. That's another option as well, but you just have to be careful. Obviously, since it is a surgery procedure, sometimes you can avoid that. If the patient continues to have flank pain and they do have a non-functional kidney designated by a nuclear medicine study, or sometimes you can even use CT determinations of a significant cortical thinning or complete destruction of the cortex with presence of CKD, you can offer the patient a nephrectomy. Moving on to cysts. So cysts can become infected. In the photo on the right, you see the right kidney has a large cyst that has kind of increased sediment and it is infected. Cysts, usually less than 6 centimeters, can be treated with lipophilic antibiotics, and usually want to do a 14-day course. They usually present almost like a pyelonephritis picture. If they fail conservative management, you can always have your interventional radiologist or yourself, using ultrasound guidance, place a drain into the cyst. Usually you want to leave it drain in rather than just aspirate, since you do want to aspirate as much as you can initially, send for cultures, and then leave it drain in. If the cyst is large and the affected cyst is larger than 6 centimeters, usually antibiotics are not sufficient enough to drain it. or excuse me, to treat it. So you do want to aspirate and drain plus antibiotics. And some patients will have repeated infections in the same cyst. Those patients need potentially further workups. You want to see if there's some sort of communication with the collecting system or if there's a nidus in there. And sometimes those patients, to avoid repeated infective cysts for the same one, you may want to discuss a lap cyst decortication or sclerosing when they're stable. So hypertension, again, is really managed by nephrology and primary care doctors. And usually, at least in the States, we're not really managing hypertension secondary to polycystic kidney disease. And again, like I said before, it's really the hallmark of polycystic kidney disease and hypertension is usually the age of before 35. And the goal of systolic blood pressure is you want to get maintained below 130. And the rationale behind that is you want to protect the renal parenchyma that's still present and not subjected to excessive blood pressure. And the hallmark of them is the first line therapy or ACE inhibitors, usually followed by calcium channel blockers. But the big thing is also having discussions with the patient about their diet. You want to avoid excess salt intake. You want to make sure that the patient's BMI is less than 25 or healthy less than 30. You want to really make sure that they're physically fit and also making sure that their diabetes is well controlled. So these are all kind of patient modifiable factors that they can do to protect themselves from developing kidney disease attributed to dietary and lifestyle factors. Again, another huge major lifestyle factor that can attribute to kidney disease is smoking or any tobacco use. So that's one thing as a constant reminder for our patients. As a oncologist, I remind patients all the time. However, for this, another reason to do that as well. And progression to end-stage renal disease is maybe inevitable. Again, it depends on how fast their cysts grow, and that there's a huge kind of difference in terms of the growth rates amongst patients. And some patients progress early, some patients don't progress until very late in life. And at that point, they have other medical issues that are competing. However, not all these patients need a nephrectomy for that. If they have chronic kidney disease, they progress to end-stage renal, and they're not having infections or pain associated with it, you don't need to really go in and perform a nephrectomy. So the indications listed down there are pain, and that's real pain attributed to either sheer volume of cysts. I've had patients where I've actually done a nephrectomy for a 20 plus centimeter cyst, causing significant compression. And I was on the left side, and I was actually causing early satiety. And a patient was having issues with keeping food down. It was not really pain related, but that did cause an element of pain. And the patient had a drainage years prior when it was large, causing that. And the patient did a lot better, but the cyst regrew. And the kidney at that point was completely destroyed. So we did a nephrectomy, and the patient did ultimately well. Infections as well. So non-functioning kidneys, almost like an XGP kidney, that have repeated infections, yes, that is definitely an indication for a nephrectomy as well. Those are technically a little bit more difficult, so laparoscopic, not unreasonable to attempt. However, in my experience, those are very have a lot of huge inflammatory kind of processes going around and do make the dissection a little bit more difficult, minimally invasive. And so I usually use open technique to take care of those. One question that I know some of my residents have even asked me too, and this is from my training days, is we've had several patients with whether you do the nephrectomy open or minimally invasive. And the question is, it really determines on how big the kidney is and how little you're going to be able to get that kidney through an incision. If the kidney is 20 plus centimeters and it's not a huge exophytic cyst that you're going to be able to drain before extracting, it may be faster and quicker to just do an open procedure, especially if it's infected. Otherwise, if you can drain the larger cyst, because most of these are not cancer, you can drain them. However, we tend not to like to drain them inside the body unless they're put in an endo catch bag. And then in terms of patients needing transplant, some patients, due to the sheer volume of these cysts sometimes can be very large, extending down into the pelvis. and they can cause a lot of issues, and that can also complicate placement of a pelvic kidney for a transplant. And so that may be an indication as well. For those, you definitely want to make sure if they're getting a donor from their family member, you want to make sure that family member's tested, because last thing you need to do is place a patient who has that, is a carrier or actually has it, and it's just not as visible. And then renal masses. Most of these patients, like our end-stage renal disease patients, they tend to have papillary RCC, so a little bit less aggressive than a clear cell variant. However, these patients, if the patient has a completely non-functioning kidney and they have a renal mass, it's usually straightforward to just remove the kidney and do a nephrectomy, open or laparoscopic, or whatever everyone's comfortable with. And really talking about our role, which I've alluded to in kind of the four major states. Again, we do have a very limited role. However, we do have a role as almost the guardians of the kidney. This is a medical genetic issue, and so therefore we are kind of limited in our role. And this is something that's not curable. And I'm going to go over kind of a new medication that was approved in Europe. But it's one of those disease states that's really difficult to manage. And you really want to manage the symptoms needing procedures. And that's where we get involved, at least in my practice and a lot of urologist practice that I know of in the States. And we're usually only involved when it becomes issues with infections and pain. And then if the patient has a renal mass and they have polycystic kidney disease and they are not end-stage renal disease, you want to perform a nephron-sparing surgery or procedure. You absolutely want to avoid removing the kidneys, since you know they're going to progress to CKD and or end-stage renal disease given their disease state. So almost like a von Hippel-Lindau type of picture, where nephron-sparing surgery should be the mainstay of managing these renal masses, and you want to kind of push the envelope for a partial nephrectomy if you can, if it's not amendable to a cryoablation. And just because you need to preserve as much kidney parenchyma as possible. If you can spare as much kidney parenchyma as possible with an ablative therapy, that is the preferred option in most situations. And again, patients, if they have hematuria from polycystic kidney disease, even though it's rare, only about 5% of cases, you still want to perform a complete hematuria workup. You don't want to only attribute it to this. This is not one of those ones that you just say this is only to this. You want to make sure that the patient gets a complete hematuria workup with a cystoscopy, cytologies, as well as some sort of upper tract imaging with a renal ultrasound and bilateral retrogrades, or intravenous pyelogram, whether that's CT or on table. And then a newer treatment that's kind of come out relatively new, that got approved in Europe, is tolvaptan, which is a vasopressin receptor antagonist. And essentially functions as blocking the vasopressin receptor, which slows cyst growth. This is not it's not a reversible, it doesn't reverse cyst growth or reverse kidney destruction secondary to cyst growth. It just slows the cyst growth. And again, this is not a cure. And this is really based on this big Tempo 3-4 trial based out of Europe. There was a phase 3 trial where they compared they had patients with autosomal dominant polycystic kidney disease, and they gave them either placebo or this medication. And really what they found was there were two things. One, that there was a slower growth in the kidney volume per year. So the TKV is total kidney volume per year. So you can see there was only 2.8% change in growth versus 5.5 in the placebo arm. And that growth is essentially correlated to cyst growth. And in theory, if you can slow down cyst growth, you're decreasing parenchymal destruction. And then also this change in slope in renal function. So all patients had a decline in their renal function, and that's the estimated GFR. However, those patients did on the medication had a slower or less of a change. And if you look at the demographics of these patients, they were pretty equal. There were very minimal change or differences in the cohorts, and both of those are statistically significant. So there is some benefit to this medication. It is not being used or approved in the U.S. As of right now. And if you look at the side effect profile for the patients, it is there are significant good amount of side effect profiles, and thirst being the most common. That should make sense given it's blocking the vasopressin receptors. So you have more vasopressin and ADH kind of hormone molecules circulating this system, so it's going to stimulate thirst. So you do have more polyuria and more thirst. However, you can see though, which is actually quite not statistically significant. However, pain did improve on patients who had were on the medication. You had patients who had decreased also nausea and UTIs and hematuria. The hematuria and UTIs were actually significant. And you look at the kidney, like back pain and kidney pain. So if you look at almost those factors of patients being on this medication and kind of symptomatology, this medication does seem to be helpful with kidney pain, UTIs, and hematuria. However, at the cost of thirst, polyuria, even nocturia. So those are things to kind of be aware of. But the medication does seem to have some promise, and I think there is some benefit in this medication. So really, kind of just concluding up, this is a genetic disease that is progressive. To date, there is no known cure for it. And really, this involves multidisciplinary care with nephrology really being on board, as they need close follow-up for blood pressure monitoring, dietary restrictions, and monitoring of their kidneys as much as we can. Urology really needs to be involved with that, especially if there's surgical interventions that are going to be needed, and you really want to help manage symptoms. And again, really for us, pain and urinary tract infections and hematuria are the mainstay. Again, there is a limited role for surgical interventions, like we discussed. Cyst, lap cyst, decortication, very large cysts that are not amenable to aspirations or recur and causing pain or obstruction, or hydronephrosis, renal cell carcinomas, or non-functioning kidneys causing pain. We really want to focus patient care on preventative measures, so dietary modifications, controlling the blood pressure, and making sure that informing family members. And the next step forward is really the future medical therapies, such as the vasopressin receptor antagonists, figuring out ways where we can slow the progression down. Because at the end of the day, the mainstay of this is end-stage renal disease, and that is what prompts patients to go on dialysis, which we all know is a huge disruption of quality of life. Two is it has a huge factor in healthcare associated dollars. But three is there's significant morbidity and mortality associated with patients being on dialysis. So if we can slow the progression of this process down, we'll be helping our patients significantly. With that, that's the end of my slide deck. I'm happy to take questions as you guys see fit. I'm gonna stop sharing my screen. You can put questions in the chat or feel free to speak up. Yeah, go ahead.
Hello, thank you very much for the presentation.
Of course.
I'm Frank Asimwe. Sorry, I came in a bit late in the middle of the presentation. I had a heavy clinic. In management of cysts more than 6 centimeters, you rightly said we need to aspirate or drain and then manage with antibiotics. If you had to put a drain, is that to drain it slowly? Is that to drain it over a couple of days? How long should the drain stay? And what's the advantage of draining over just aspirating? And secondly, do you instill a sclerosant? How do you manage and prevent reaccumulation? Thank you.
Yeah, so for an infected cyst, the rationale behind aspiration and drainage is, given the infection, you want to make sure that you leave a drain in there you can to clear out any residual infection. And usually, if the daily output is less than 20 cc's, then that's usually good enough to pull the drain out. And some patients somehow have increased production, or they still have fluid coming out, and you leave it in a little bit longer. These are not long-term drains, and so these are usually with only between the order of 2 to 5 days most of the time. And your second question in terms of the reaccumulation, so I tell patients there's about a 50% chance of reaccumulation of, if you have a non-infected cyst, and there's a large cyst causing huge pain and issues, and they want a cyst aspiration. I usually recommend cyst aspiration with sclerosis, because that decreases the recurrence rate, and you can use a sclerosing agent like doxycycline. Sometimes we do that for hydroseals as well. However, I only recommend a lap cyst decortication for patients who have reaccumulated more than twice for a cyst, and that are otherwise healthy surgical candidates, because I do think that they do have good outcomes with a pure lap cyst decortication. But then again, it is a general anesthetic, it is a procedure that they have to undergo. But that's usually my threshold for that.
Thank you.
Mm-hmm.
Can I ask another one?
Of course.
Thank you. Since it's obvious, if it's persistent kidney disease, they are likely to eventually end with end-stage renal disease, needing dialysis and possibly a transplant. Would you recommend a preemptive transplant, and at what stage would you begin the discussion for transplant? Thank you.
Yeah, so that's a good question. So usually it's a kind of combination discussion with nephrology and seeing with the trajectory of their GFR decline. And if they're already at stage 3B or more, that's when you start having the discussion with transplant surgery. When they're almost their GFR is teetering around 20 or less. When they're coming down that close. And it really is depending how fast they decline. So some patients decline quicker, and so you kind of need to have that discussion earlier. But I can tell you that I've had not too many patients, but I've had 1 to 2 where I've seen whether there was question of the cyst was a questionable cyst, whether they were concerned if it was a cancer or not. In getting involved in, obviously that brings up a whole slew of issues with being listed as a transplant, and you telling nephrology and transplant no. But those patients are usually having those discussions about a year out before the expected progression to end stage.
Thank you.
Yeah, go ahead.
Thank you very much, Dr. Patel, for the presentation. I have 3 questions. For cyst sclerotherapy, do you always need the fluoroscopy, or you trust the images done before that there's no communication with the collecting system?
Yeah, so it depends. If you get a CT intravenous pyelogram, then that is or CT urogram. That's usually it's usually a good that's a good test, because you will have a good chance of looking at the connection. If there's some suspicion, if a patient has recurrent infections and that urine culture is the same as, and you've had an aspiration, then you should have a high suspicion. Sometimes you can get these weird communications, and yeah, that's someone that you'd usually want to take to the operating room and do a retrograde pyelogram, or even read pyeloscopy and look up there and see if there's a communication, and do a direct retrograde pyelogram up there and see if that is. Rare, but usually these end up being, quite honestly, they're not cysts, they end up being blown out calyces from infundibular stenosis.
Okay, and you talked about testing a family donor. Did you mean genetic testing or with imaging?
So usually you can do the imaging first. I wouldn't check with genetic testing, expensive, but also not available to everyone. So if you did a simple renal ultrasound and the patient has no bilateral, if the patient's doesn't have any cysts or only doesn't have bilateral renal cysts, then they most likely do not have it. So that's sufficient enough. If they have bilateral cysts, then yeah, you may want to follow up with genetic testing.
Okay, my last question. Following genetic counseling, do most patients choose not to have children, or they go ahead and give the gene to their children?
Say that, sorry, you cut off for a second. Say that again.
I'm saying from your experience, when patients are counseled about this autosomal dominant polycystic kidney disease, do they then do most choose not to have children to avoid spreading the disease, or some of them take the chance and
I would
father
say
children?
most of them, and it's very dependent on how severe their polycystic kidney disease is, but most of them actually choose to have children, and usually they have, most of the time they keep, at the time I'm seeing the patients, most of them already have kids, and then they end. So at that point, they already have kids. They're usually younger than those. They're usually testing their kids early. I think I've only seen one in training that was diagnosed early, where before they had kids. But most of them already have kids by the time I've seen them.
Okay, thank you. Those are my questions.
Yeah. And then there's a question in the chat: is there a role for bilateral nephrectomy for purposes of stronger consideration for transplant list? Yeah, so since these are not malignancies, usually if it's a big conversation with the transplant surgeon, and if you have space to place the kidney in the external, like, big cyst disrupting that ability to do that, sure, you don't need to do it. However, a bilateral polycystic kidney disease, or having bilateral renal cysts with polycystic kidney disease, should not alter your ability to get on the transplant list. However, if patients have progressed to end-stage renal disease and are completely anuric, then they may want to, but that is not a contraindication to be listed, at least for us. And then, since the disease is progressive, is it bad to tell clients to start saving money for transplant as soon as possible and make the diagnosis given initial high cost? That is, I guess that's an interesting question. I know, like, obviously healthcare is a little bit different, and obviously where the regions we're at. But yes, it's end-stage disease. It is the fourth leading cause. It's essentially inevitable. Some people don't progress all the way to end stage and needing dialysis. Some teeter on that CKD, not needing dialysis. But yeah, I think telling patients that there's a good chance that they will ultimately need dialysis, and so they can mentally prepare for that, but also if that includes financially preparing for that, I think that's good advice you can give them to say to prepare. However, I would not 100% of patients go on dialysis. So that's something to consider. Any other questions?
If that's everyone, I want to thank you, Dr. Patel, for all your time, and
Of course.
thank you everyone else for helping coordinate. This is such a great attendance and such a great lecture.
Thank you, everyone, again, for taking your time. I know it's later in the evening. If you guys have questions or concerns, you guys are more than welcome to reach out to me. Do they have my email or contacts, or like the Twitter handle or whatever on IVU?
I can send all the registrants that if you want.
Yeah, if we can get that sent to you, so you guys have further questions, stuff like that, or even if in the future you guys have issues with questions about patient care for urologic oncology issues, I'm happy to help out as much as I can.
Yes, and Galina, I'll send the recorded lecture, and then Dr. Patel, do you mind sending me the PowerPoint?
Yeah, no problem.
Okay, cool. All right, thank you, everyone.
All right, take care, everyone.
Yeah, thank you.
Thank
You're
you.
welcome.
Thank you.
Have a great day.
You as well.